Good evening, and I want to thank you all for attending tonight's webinar. Just as a matter of history, this was a symposium that Jimmy Andrews and Tony Miniacci and I were part of at the American Academy of Orthopedic Surgery meeting last year, and it got a lot of excellent feedback. I wish they were also part of this because they did a terrific job in presenting their side of it. Mine is sort of one person's view of the world, and in some ways we all kind of meet in the middle. It was very enjoyable, and the content tonight is based upon one piece of that symposium. At the end of the presentation, you'll have the opportunity to ask questions, and we'll have probably at least 30 to 40 minutes to do so, and then this will be able to be viewed through a link after the webinar has run. So thank you, and I hope you enjoy the next 18 minutes of the presentation.
And I'm going to show some cases, and I would just ask not to record or photograph the cases, just from even though I have permission to use them, I just think it's probably the right thing to do. Experience-wise, so I'm 13 years with the Chicago White Sox as co-team physician, head team physician, but been head team physician for the Chicago Bulls for 12 years, 14 years with D1, and then 4 years with Arena Football until it passed away in Chicago, and now we're actually seeing it come back again, and we're going to take care of them again. Am I qualified to be here? Well, I mean, compared to the next two speakers, I'm not totally certain, but I've taken the liberty just to sort of take inventory of how I spend most of my time. And I would say the things that I probably derive the most pleasure from are going to be family and recreation, but also the privilege of managing athletes and sports coverage, and I'll share some of my experiences. It really begs the question, when you have these challenges, why would you even do this? It's been said by someone, I don't know who, if any of you guys know, I'd love to hear, but that if you want to get something done, just do it right, just give it to a busy person. And I think that's, when you look across the board, who does team physician, team coverage, they often have very busy practices, very busy lives, and balancing it all is a particular challenge. And when you really get down to the core issue and you say, well, why do you even do this? It's the same reason you and I sit in this room, is because we still enjoy helping people. I was just recently at the NBA All-Star game. This is a fellow from Canada. He's a soccer league player there who had really been out of options, and big-time surgery, DFO, OA grafted, failed microfracture, was malaligned, and he is now getting back to soccer. And when you actually you derive that pleasure, it's not about what you get paid. It's all about getting an outcome like this, and it constantly reminds us, especially given the challenge that you and I have to deal with on a daily basis with all the bureaucracy and legal and everything else. This is really what it's all about. And I think one of the most important things is surrounding yourself with people who are better than you. And I will tell you that for me, role models have really been what it's all about. These are just a few of many people who have had huge impacts on my life to help me think about my day-to-day decision-making. Freddie I trained with as a fellow. Neil Atrash I continue to learn a ton from on a day-to-day basis in management of athletes. Jim Bradley has a wealth of experience. Bernie Bach, my senior partner. In the bottom right is Russ Warren, and in the bottom left is, of course, Jimmy Andrews, contemplating away. And then in the middle there is my father. And all these people have had a huge impact on my life, as many more that would really require mentioning, but not enough time. And so what about the head team physician role? Well, as Abraham Lincoln has said, look, nearly all men can stand adversity, but if you want to test a man's character, give him power. And I will tell you, in the role of team physician, maintaining character and ethics and communicating with others is sort of what's paramount to being successful in this role. And you say, well, who gets to do this job? This sounds like something I would love to do. And these are some of the mechanisms that many will sort of go through to have this job. And they're either chosen by the organization. It may be as an at-will consultant. Sometimes individuals now are chosen and actually inserted by the hospital. There is sometimes compensation, but sometimes it's pro bono. There's other benefits that you get sort of economically, if you will, free tickets, if you will, parking, and there's even some team physicians who actually get bonuses if you make the playoffs. And then there's other issues that may be paramount to sort of the expense structures. Look, you either pay your way or you actually get your expenses reimbursed. And these are sort of the background noise of what happens when you're in this role. And there's really a lot of things to consider if you assume this responsibility. The first is your motivation absolutely cannot be driven by finances. And it takes a lot to understand the commitment. One of the things that we have to do on a regular basis is to know how to grade athletes and predict risk, because in essence, this is like an asset that you're evaluating, and you're trying to estimate a return on investment. You have to be prepared to help an athlete get a second opinion. You're going to hear that time and time again from the next two speakers. It is all about relationships with other professionals, and you're going to learn a lot about that, and I think you're going to probably hear the most about that from Jimmy. There's no question that fame is not part of the equation, and being starstruck is not an option. I always joke around, half the time when I'm seeing an athlete, I have no idea what his name is, what position he plays. I'm probably the worst person to be in a role. I know nothing about sports statistics. I love sports because I like athleticism, I like keeping people playing, but I know so little about the statistics and other sports and what these guys do. You know, when you talk to others, they're just head over heels into this thing, and from my point of view, it's all about making decisions and trying to get them back, and that's the gratification that comes from it. And I think the other thing you have to know is that the impact on your reputation is not always positive, and you really need to be prepared for that. This is probably the most important point. This relationship between a physician and athlete is categorically a fiduciary responsibility. It's really a duty of good faith. You have to have undivided loyalty to the athlete. You know, players trust their doctors with the most vital service that they can get their hands on, and this is a very high-risk occupational problem. And at no time should an MD actually profit at the athlete's expense. And there is no training for this. You know, this is on-the-job training. It takes a lot of common sense, frankly, and basically just understanding the human condition. The big role is overseeing the medical team. You're sort of the quarterback to champion all these other specialists. And you know, Mark Twain had a great expression, really great people can make you feel that you too can become great. And that's an important statement because bottom line is you have to enable a very large team of individuals. It's not all about this single individual who's doing this. And the job description is really varied. I just did this last week for the fun of it. I did the Bruce protocol, which is what all of our athletes go through. And it took me like 18 minutes to get it done. It was actually very hard. So those of you guys who manage athletes, that's something they have to go through. It's a good idea to sometimes put yourself through some of those tests. But really, this is all the stuff we do. And it ranges from the pre-participation physical to dealing with nutrition supplements, banned supplements, updating injury measures, return to sport. I mean, all the things you might think about as a team physician, we have to deal with these issues. And what I've learned is, you know, we use this expression a lot, there truly is no I in team. And I can tell you at Rush, with our group, it is a large group of us who have to manage this. There's no possible way I could cover every single game. Traveling for the playoffs is an enormous responsibility and burden. This really a 12-month-a-year job when you're a team physician for almost any sport. And if you take care of multiple sports, it can really occupy a big part of your life. So this is sort of what it looks like. And the athlete, a good way to think about it is this hub and spoke model. The athlete is, you know, euphemistically at the center of the well. And you've got all these other people that you have to help manage. And we use this acronym SCORE, which is you have to support it, you have to collaborate, oversee it, and be ready to refer when necessary. And there's a lot of really interesting literature out there that discusses the responsibilities of being team doc and so forth, but I think the biggest take-home of all these responsibilities is you really need to be available 24/7. These guys, the organization, they need someone to rely on, and it is absolutely categorically a 24/7 job. These are some of the intangibles. I think you need to be prepared to encourage second opinions, and not only encourage it, actually help arrange them. I can tell you in any given week, I'll be texting, thank God Jimmy stayed in the 21st century because I can text him an x-ray, he picks up, he responds literally within 5 minutes. I don't think it's ever been longer than 5 minutes, unless you're on an airplane, and my guess is even then you're responding. So it's very important to help get it done. The agents expect it, the patients expect it, and you learn a ton from these second opinions. And if you're ever uncomfortable, we'll refer. And if I feel someone can do a better job, I have no problem referring these patients. And as I mentioned, you're kind of the quarterback. You're coordinating care. You're not always delivering it, and you need to be ego-substantial enough that you can really accept the fact that you're not going to be the point person other than helping to coordinate it. I think it's also important to remember that these guys are patients first and they're athletes second, and that there is a life after sports for most of them, but not all. So for many of these people, their entire livelihood is banking on that contract period, and when that's done, some of these individuals will have nothing left. They're consumed, essentially. We have an obligation to know the most contemporary treatments available, and I will occasionally recommend safe but unproven methods. If I think it's not going to hurt them, yet the data isn't there, their economics generally isn't an issue, I'm fully willing to embark on some of these unproven pathways. So I think it's really important to help these guys search for a very safe, low risk, but high probability solution for their problem. And I'm never really afraid to say, look, I'm not sure I know the proper answer. This is a new thing to think about, but I'm going to get back to you. Make calls, do research, and do it quickly so they know you're on top of it. I'm just going to cover some of the issues that come up that I found sort of really pervasive in my day-to-day life. And this is one that's a little bit difficult to articulate and help you understand, but this concept of agency. And I don't mean agent, I just mean agency. Who do you respond to? Who is responsible for you and vice versa? And your credibility really depends upon what lens you're viewed through, and also the timing of the decision, where the athlete is in his or her career. And all of these players play a significant role. The player, the agent, the owner, the GM, the trainer, and the fans. And every one of them may be looking through a different lens. And here you are stuck in the bottom trying to make a decision when everyone's got an opinion, and their opinions have nothing to do with the medical character of what you're dealing with. It's about everything else, and you still have to be a doctor despite very different forces that come from every one of these sources. Probably one of the biggest challenges that we have now. The other thing is there really is no loyalty in this field. If you look at it, physician-employee model is exponentially growing. This is taken off this little vignette, Walk It Off Champ, where they looked at the level of trust that NFL players had for their team physicians. 80% of them, I think, or greater, at this time of this survey, said that they distrusted the team physician. Okay? So the statement from that article, these hospital arrangements include reduced rate medical care and or a payment from the hospital to the team in exchange for medical provider getting to market the affiliation. Think about that. If you're an athlete and you're pushed through the system and you're taking care of that team and it hasn't been vetted in the traditional ways, that can potentially be a huge source of conflict. And I know you're going to probably hear more about that. What if they go somewhere else? What if they go out and they get the Kobe Bryant procedure from someone who may actually indeed have the cure for arthritis, or at least contemporize the symptoms? How do you deal with that? So these are things where you absolutely have to maintain an open mind, right? We get nowhere by criticizing another individual. You have to be objective, understand these athletes are looking for alternatives, and be very supportive and try to provide alternatives, especially when something may or may not make sense. And it's okay if it's unproven, if it's not going to hurt them. Sometimes you have to just swallow it, even though you know it may not be the right thing, and just let it go. What about malpractice and liability? In general, we are at-will consultants with insurance riders. So traditional malpractice, and then you pay a little bit more to get a bump up in single and total claims. The ideal scenario would be is I could be an employee of the organization, because in general, if there's an event, right, that could potentially pierce that corporate veil or go on to personal assets, for example, if you're an employee, you're relatively protected because of the workers' compensation status. That's been challenged in litigation, but that's the ideal scenario. But not every sport or organization is willing to put you in that position. And I can tell you in my own life, I have nothing in my name. I mean, at this stage of the game, the risks are so high and the incidence of liability is so high that you have to have really, I don't know, I'd be interested to hear what the other speakers do, but you really do need to have a layered protection plan, because trust me, those of you who've dealt with the plaintiff sector and so forth, it is a brutal, brutal environment. We all have friends who have not only had malpractice cases, but have had malpractice cases that have pierced the corporate veil, gone to their personal assets. Not a lot of fun. Training room. This is really the heart of what we do and where relationships are forged. That little cute video on the bottom right is my vertical is about 6 inches, and Derek's is about 5.5 feet. So I try to, what I do is I have to arrive at a game about 2 hours before. That's where I get my exercise, see players, and I'll work out there. Try to stay out of their way and not be noticed, and it's not hard when you're 5'7" 3/4" and everyone's 6'10", so kind of stay in my little corner. But the point is, they know I'm engaged, they know I'm there, and I'm always available. But this is really where relationships are forged. Sports medicine, in my opinion, has become somewhat of a commodity, and it's really all about decision making. And I like to use this concept when I teach residents and fellows, this concept of linear reasoning. Most people want to know how A gets to B and B gets to C, but the reality is there's often very little connection between A and C. You know it and I know it, but to help people understand that is a very big challenge. Imaging is one of our biggest challenges that I deal with on a day-to-day basis. So this is someone who had an MRI reading that says, hey, he's got a contusion and he's got a stress fracture, right? These are two things you may want to take home, and this is what I use all the time in my office. The first one is BARF. That's the brainless application of radiologic findings. And there's a very close correlation to BARF, which is vomit, which is being a victim of modern imaging technology, right? You and I have to explain these things away on a regular basis because of the emphasis on MRI findings. We know from our work that abnormalities, for example, in the knee are extremely common, So try to explain this to an agent that, look, he's got arthritis, he's got a meniscal tear, but he's completely asymptomatic. Try to explain that to a GM that they shouldn't give him short money or short time or vice versa is a big challenge. Jimmy will probably say this in his talk, but this is something I learned from him. He says, look, if you want to operate on an overhead athlete, just order an MRI. You'll find a reason, right? You'll hear him say that. And that's true. 50 to 70% of our baseball players have abnormal MRIs. So if you're looking to find a reason to operate, just get one. This is a very common question. If I stay active, because we're often asking athletes with known pathology, to stay active, will we make it worse? I can only tell you in the knee, the literature is very unclear, and there's not a clear correlation with the advancement of arthritis and activities. What about variable responsiveness? This is a really interesting area, something we're becoming particularly interested in. We think about all these other variables that we can modify, but there's one that we can't, and that's a patient's perception of their problem. You know and I know you can walk in a room and you can tell who's going to be responsive to your treatment and who's not. People have this propensity to catastrophize their problem, for example. So getting inside the head of a patient is a lot more important than understanding where their meniscal tear or where their labral tear is. So it's all about managing their expectations. And in many respects, what you and I do is not an off switch, but it's a light rheostat to sort of down-regulate what their outcomes are. We have to be able to provide safe alternatives, and this is always the first-line treatment. But when it comes to surgery, we want to start out and say, look, have you failed non-surgical management? Is the magnitude of your pain and dysfunction unacceptable? And if it's not, then surgical intervention is an option. And then you have to ask them, what is it about your problem that you want to see improve? And then if you're going to offer them something, whatever you're going to offer has to predictably lead to that outcome. And then what you learn, especially with a managing athlete, is sometimes doing less is more. So we're looking at an arthroscopy and a debridement as a first-line treatment, for example, to get an athlete back over doing something heroic like an osteochondral allograft. So just give you a case example. This is an NBA guard, patella defect, right? Recommended to have surgery, has an arthroscopy, and does very well. And he comes back and he's been told that he needs to get that defect fixed. So it's a great quote from Voltaire. The art of medicine consists of amusing the patient while nature cures the disease. A little reassurance goes a long way with these guys. So I'll tell you, that case example, NBA guard, index treatment 6 months later after scope, he's been told 9 months later, you got this defect, it's going to progress, you should get it fixed. With 14 months of reassurance, rehab, and everything else, he's back, returned to play at a normal level, never having surgery. So it's all about balance and how you balance your time in terms of family and work and sport and so forth. These are the things that have been most important to me, and then I'm going to finish up out of respect for the other speakers. First one is I've tried to identify non-negotiable time for me, something that is my time that no one else can take away, because remember, this job is truly 24/7. So I have time that I block for me. You can fill it with whatever you like. Just don't ever try to justify it. It's yours, own it, and don't let anyone take it away from you. Always be a student. Tony Bennett, there's a great little article. Tony Bennett says, look, I'm really a student. No matter how much you know, there's always much more to learn. We're really never done learning. Be ethical. And Jimmy's taught me this as much as anyone else. We took a Hippocratic oath to do no harm and just do what's right, and we never benefit from disparaging our colleagues and our patients. Set your priorities. This is Harold Kushner's book. I never met a doctor on his or her deathbed who said, I wish I would have spent one more day at the office, seen one more patient, or did one more surgery. Learn to say no. So I always ask what I call the magic questions. Will it enhance my career? Will the commitment take me away from my family and my friends? And will the obligation take me out of balance? Make a difference. And this is what I started this talk with. Look, we are really incredibly privileged. Are we making a difference in the world? Ian Jackson's a plastic surgeon who took this gentleman out of Africa, did 25 surgeries on him that were craniofacial surgeries. Are we really making a difference? What will the dash say about us when it's all said and done? Quality over quantity. You know and I know you can spend 5 minutes with a patient, but if the quality is good, they're going to think you're there an hour. You don't want them saying the doctor was in and out and I never saw him. And the other thing is just put it away. The electronics are just an absolute epidemic. It's infectious. Figure out ways to keep that out of your life, especially when quality time matters. If you become a team doc, we're doctors first, but give them something to believe in and don't cross boundaries. That's a really important one. I remember having that conversation with Neil Alatrash about level of boundaries, and I'll never forget it. And it's incredibly important because it's very provocative to build relationships with these guys. But if you cross a boundary, you lose your efficacy, you lose that trust. Exceed their expectations. Find out what they want and give them more of it. Find out what they don't want, give them less of it. And ask yourself, would you go to a doctor like you? And finally, be happy. Always pursue happiness and just start right where you are. by Chris Gardner. Thank you for your attention. I appreciate it very much.
Thank you. So one of the first questions is that, obviously you have a great experience with pro athletes. What are the unique obstacles regarding the Olympic level athletes? When we first did this as a instructional course, I had Scott Rodeo, who has been very involved with Olympic swimming. My guess is he's there now, actually. And the Olympics is an enormous time commitment. It requires a pre-Olympic training camp that I believe is several weeks long. And then it's not like they can go to part of the Olympics. They're there for the entire time. But it looks to be one of the most amazing opportunities I've seen as far as the ability to cover athletes. The other thing that's fairly unique is the significant emphasis on the WADA restrictions as far as performance-enhancing drugs and issues pertaining to, I'm just going to turn my camera on, and issues pertaining to drug use and so forth, which obviously we get that in professional sports, but those are often under random drug testing and so forth. It's something it occurs on an ongoing basis at the Olympic level. But I say what's unique to it is clearly the time commitment and a very, very strong emphasis on evaluation for the potential use of performing-enhancing drugs. Let's see. How do you manage sports performance specialists that are brought in by athletes to the locker room? That's a great question. Well, yeah, so, we deal with that, and I can tell you we certainly have had that experience both with the Bulls and the White Sox. And, the one option is to consider just having a policy where you can't do it. But one of the things that I think we've learned is that when you start to put up obstacles for these athletes, it creates a level of distrust. It creates some inertia. So I think one of the things that we emphasize is that we generally will allow it within reason. But what we try to do is emphasize communication. So whoever that individual is, I mean, it's amazing the spectrum of people you see who an athlete will trust. It can be someone who has a tremendous amount of training, or it can be someone who has no training whatsoever, but it's someone that they have known for a long time, and they just have a high level of confidence in that individual. So I would say that in general we have tolerance, and we encourage them to communicate with our trainers and strength and conditioning people to make sure we're not overlapping and not getting training that's outside the spectrum in terms of something that can lead to overuse. Another question, what are the unmet needs of athletes? What are the possible reasons behind athletes being unhappy with their care? I think the biggest challenge is this issue of trust, and I alluded to it in my talk, that I think sometimes athletes are confused as to who we work for, and this can be something at the collegiate level or the professional level, and helping them understand that we really see them no different than patients, but rather they're patients that function in a system. And the decisions that we make are always medical in nature in the athlete's best interest, but at the same time they're where we think about them in the system, their agents, their family members, all of these other people that weigh in to help make these decisions. And I'll tell you that that's probably the biggest challenge, because we are their agent and help them understand that, look, we're not asking them to return to play, for example, because it's in the best interest of the team. We're asking them, we're telling them that, look, it's not likely you will injure yourself any further, and it's very safe for you to return to play. And getting that across and not compromising an issue of trust or the perception that you might be asking an athlete to go back before he or she is ready is a really big deal. So I think that's probably one of the biggest challenges that we have. I'm not sure I addressed the unmet need issue as far as athletes go. I guess I would think that education of these athletes and actually, being willing to confront, you have to remember that lots of these individuals are very young. They have often skipped a couple of years of college. They may not be completely armed to manage all of the challenges of being a celebrity. And I think that providing a system where they can comfortably communicate, ask some of the difficult questions is a really important aspect that is not always met. They have to trust. They have to work with their agents, and hopefully their agents can provide an environment where they can tap into things that don't relate directly to the sport, but have to do with their the celebrity nature of what they do and the very public nature of who they are. And I think resources related to that are probably not ubiquitous. Another question, what are the primary things to consider when grading an athlete for professional sports? What predicts a good investment? That's, gosh, another really a tough question. The primary things that are the big deal ones are obviously not even orthopedic, they're cardiac. So family history of death at a young age and any known cardiac history in that particular individual is probably one of the highest risk situations as you might gather. On the orthopedic side, the teams will use many different systems, and especially when you're doing a combine type situation where you're evaluating an athlete, we'll typically grade them, say, for example, on a 5-grade scale. And very few people come in being perfect. If they've had any injury whatsoever, it downgrades them a little bit. But I think that the most important thing that I tell everyone is that the past predicts the future. If you have an athlete that's had, for example, a surgical issue that's had intervention, let's just take an ACL, if they have demonstrated the ability to be back for a year or more, we kind of know they're okay, and we all know what their risks are, for example, for a re-tear. Same thing for, say, shoulder instability. We've had a couple of athletes we've managed with traumatic shoulder instability, and we said, let's give this a try to get back, and we all know what the recurrence rates are for collision sports, but every once in a while you get an athlete who's had just a soft tissue injury, no bony component, who can actually survive additional play without redislocating. So as far as evaluating risk, if they've been back with a known condition, whether it's been treated surgically or through, say, benign neglect and rehab, one of the big issues is actually seeing how well they performed, that they actually got back to their level of sport for some period of time, and that can actually help reduce risk. So what's a good investment? Some of this is luck, to be honest, and some of these injuries happen traumatically that we can never predict. But I think a good investment is trying to understand the natural history of disease. It's very difficult, for example, in cartilage. When they've had previous cartilage problems, they have some sense of what might become symptomatic again. And unfortunately, surveillance MRI and CT and X-ray doesn't really do a good job of helping us predict who's going to become symptomatic, as there's a huge disconnect between what we see and what we can predict. But a good investment is one who we do a really good job of helping to predict a condition that hopefully will not become symptomatic. Do we use stem cells to help surgeries heal? The answer is, there's over 500 stem cell clinics now across the country. The FDA is threatening to sort of lay down the hammer in this area because of the absence of strict regulation. There's a very low bar to use bone marrow aspirate concentrate, for example, and even to use adipose tissue in some instances. It falls under what we call the 561 pathway, which is basically tissue used for homologous use. And and it's not removed from the operating room. It's done in a single operating room setting or in the office. So I will tell you that Rush have not ubiquitously adopted the use of stem cells outside of research purposes. We have 2 clinical trials that are ongoing. One is in the area of rotator cuff repair to try to repeat a study published by Hernigo and his authors showing a reduced re-tear rate with the use of bone marrow concentrate. And we're also involved with a de novo study looking at the effects of arthroscopy, the outcomes when someone has both meniscal tear and osteoarthritis to see if bone marrow aspirate concentrate might make a difference. I will tell you, in athletes, we have a very low threshold to use things that are unproven as long as they're safe. So I will use stem cells in our athletes post-operatively in various situations. And what are they? We'll either use bone marrow aspirate. We may use some of the amniotic products, and we may use bone PRP, which is obviously not stem cells. But I think the general dictum is that things that are safe can be used even if they're unproven because, frankly, economics don't play as big of a role. This doesn't fall on a personal responsibility. Another question, when I was a fellow, I was working with the NHL. I want to just check one thing. Kelsey, they cut off. I don't see the entire. I think there's only allowed a certain amount of characters when they ask a question, so I apologize. I don't see the end of the question there. What advice do you have for a junior resident considering a career in sports medicine and hopefully to work with high schools? That's a great place to be. And if you work in a community where you basically help them understand that you will allow them to have access, that's a really big deal. I think, as I mentioned, one of the most important issues is to have 24/7 access. And how I would manage that as a young physician who wants to get involved in helping our athletes at the high school level is incredibly gratifying. I would say that you go to the school, you meet with the athletic director, you meet with the trainer if they happen to have one. Keep in mind that there's always that risk of stepping on the feet of others who might have a relationship with that team. You do your best to sort of lend a carrot, lend a stick to have a collaborative relationship. For example, sometimes there's individuals that have been doing this for a very long time and they don't have the schedule to cover every single game, and offering your time and saying, look, I know you're the guy, but I'd love to help, and anything I can do to assist you, and even if it's game coverage or if you're out of town, I'd be happy to do that. And I think if you have an amicable relationship with the trainer, the athletic director, and the current existing team physician, if they should have one, that could sort of put you in the best position downstream to not be seen as a threat, and because obviously there's often a lot of ego involved here, and that you're there as an asset. Let's see. Do you deal with high school teams, or have you recently? What is your approach to the overbearing parent? That's a great question. Even if you don't take care of a high school, we all, many of us who do practice sports medicine, see young people who come with their parents to the clinic, and frankly, I find that one of the most interesting interactions, and I'm sure many of you have had the experience would agree. What's fascinating is what, obviously the perception of the parents in some instances is that that child is going to be the next Major League Baseball player. And there may be differences between the parents in terms of their perception of that child. Some of them are inexorably just concerned about their future and may not want them to participate in sports. My approach is to really listen to the kid. I direct, the one challenge sometimes you find the parents actually answering for the young person, and I will be very politely say, look, I know your son or your daughter is only 13, 14 years old, but I'm considering them as an adult right now in terms of this communication, and I'd love the opportunity just to hear what he has to say. And listening, and I assure you we'll answer all your questions, but I really want to hear what he has to say in terms of how this started, what his experience has been in the sport. I try to get at it. They actually like what they're doing, because it's amazing how you sometimes find situations where the athlete doesn't really want to go back for a variety of reasons. And obviously it falls into a category sometimes where we may not be able to actually help that person no matter what we do. It's almost like a workers' compensation situation where their motivation to get better isn't high. But the classic scenario is that they're well aligned, or the parent is pushing you to get them to go back sooner. And that's the one. It's just like managing a professional team. You never get in a situation where you would compromise your judgment because of pressure from a coach, a GM, or a parent to compromise your understanding of what it takes to get an athlete back safely, predictably, and to prevent re-injury. There's a lot of discussion in that area, but I think I covered it in general. What obstacles do you see for a resident who's attempting to be involved in a high-profile athletic team, college or professional? I think that a lot of that is benefited if you come in with some degree of experience. I will tell you that, as I mentioned, this is not an individual taking care of a team, but rather it's a team taking care of a team. So being part of a bigger system, I found to be particularly helpful. In fact, I've seen many teams sort of be displaced by organizations, and not just because of high-priced marketing arrangements, but because when you think about it, it's not just orthopedic care. You're providing everything from dermatology, OB-GYN, pediatrics, sometimes psychiatric or psychology, ear, nose, and throat. I mean, you have to have access to a litany of specialists, and if you're part of a hospital system or a hospital that has all these specialists that you can sort of quarterback, that is generally a huge asset for a team. And if they've never had that and you help them to understand it, you get a leg up on that. It's very hard as an individual to manage everything. So I think the other thing that's helpful is if you're a part of a program, there are some, like I think the NBA, well, maybe Major League Baseball. I'm not certain. Maybe Major League Baseball could be the NFL requiring sports medicine fellowship and/or certification. So there are some sports that are requiring some degree of either fellowship training or certification. The CRQ, the test that we have to take for sports medicine, is given to AOSSF, and that does include your credibility and so forth. Although a lot of these teams won't know exactly what that is. But from the organization's perspective, for example, the Society for Baseball or the Society for the NFL may actually require that. So there's several obstacles. There'll be training, your experience, and the system that you're involved with, and hopefully it doesn't fall back to the level where it's just a marketing agreement. How do you balance the just need 2 more years conversation with long-term recommendations for health? That's a really interesting one, and another one like the parent-child interaction that is really, I find, fascinating because, in some respects, some of these athletes are almost like racehorses. In other words, they're a true asset, and they are trying to maximize their asset value. And they may come to you and say, and have, short-term goals. I think maybe the best example would be an individual who has a bucket handle meniscal tear, and he says, look, I just want you to take it out. And we all know what the concerns would be downstream. And you get in and you say, look, what if I get in there and there's a perfect meniscal tear back to the periphery? If I fix this, there's a 1 to 2 in 5 chance that it may re-tear, but a 4 to 3 in 5 chance that it will stay healed. And if it does stay healed, then presumably we can normalize the biomechanics across your joint and minimize the chance of getting arthritis. And not only can it potentially prolong your career, it could keep you potentially healthy as an adult when you're done with sports and being active. So I think all of you know how that conversation could go. I've heard a variety of different individual responses. Some physicians will say, well, look, I'm not going to manage the athlete if he or she won't let me do what I think is best. I look at this as a risk-reward discussion. I try to very fairly give them both sides of the equation. There is no one right answer in most instances. They have to understand to the best of our ability to sort of disseminate this knowledge, the potential consequences of one treatment versus another. And it's not only the athlete. We speak to their family. We ask for their parents to be involved when it's relevant. We ask for their agent to be involved, and sometimes the team, and have a cogent dialogue that involves all the stakeholders, but ultimately it's the athlete and the patient's decision on what he or she does. Very, very tough, very, very tough situation, but I think the best we can do is informed consent, extend to the level of having full knowledge of what each decision will bring to that athlete, knowing that there's no certainty and that there's probably more than one right answer to get it right, to get the outcome optimized. Another question is, our patients come first, but how do you continue to maintain your status as a protein physician when you have to have a good relationship with ownership? I think that what I have found is that communication and regular communication probably fosters the best relationship with ownership, the GM, and so forth. I find that the most challenging times are when there's a paucity of conversation or dialogue about the players, and even though we have injury reports that we circulate by email and so forth, there's a lot that gets contextually lost with email. And I think the thing that helps the most is regular communication. And one of the things that we're fostering now is to try to do a weekly call with all the stakeholders. It could be strength and conditioning, nutrition, psychology, the athletic trainer, the assistant trainer, the GM, the owner, anyone we could possibly get on the call, and the coach, so that we're all on the same page. And I think that helps the most. Again, I think the hardest thing is to help the athlete understand that they are your number one most important aspect of the relationship, and at the same time be able to educate ownership about the consequences of the decisions to manage their care. So it is a very tricky area, but I think the take-home is like any relationship. It's kind of all about communication and discussion, and then the other thing I think that helps is an openness to second opinions and treatments that, as I say, may not be fully proven, but they know that you're going to every length to shorten the duration of disability, minimize the time off from practice and play, and minimize recurrence and re-injury rates. And in general, I rarely hear of very hostile relationships with ownership. More common is it's a challenge with the physician dealing with various player personalities. Next one, how much are you involved in psychology or return to sport after injury for an athlete? Another fascinating area. There was a recent publication in AJSM discussing sort of the psychological variables about return to sport and the fear that our young people have after they've had a catastrophic injury that's kept them out of sport. And I'm involved with it all the time. I actually it's less about what the MRI and the X-ray shows and more about the individual. I showed you that slide about the intangible where it's that patient-specific axis that really factors into as a very important independent variable in terms of how successful we can be in treating that patient. And it takes a lot. You need to sit down, be a good listener, and try to get inside the head of that individual to know that you're someone they can trust and that can ask some of the hard questions, because you'd be amazed at what they fear. It can be economic loss. It can be the pain of surgery. It can be needles. It could be someone whispering in the ear who's a family member or related to them, from the agency and so forth. So trying to be, I think, being a really good listener and not being afraid to ask some of the tough questions are probably some of the key variables when you're dealing with the psychology. And the other thing is that having resources for these athletes. I think in some respects we have to stay in our lane. They have to have something to believe in, and we're not experts in everything. And if I ever have a concern, there's people I can turn to say, listen, would you sit down with that athlete and ask him or her if they would like to sit down and talk, and that could be a psychologist, and rarely a psychiatrist, but it's usually a psychologist with the experience in return to sport and performance-related issues. Very, very big issue that's probably underserved at virtually every level of sport. So I'm not seeing any more fresh questions. Still a lot of participants online. Anyone we're good till 8, but if there are no additional questions, we could clearly end early. And if any of you guys have any questions, I'm more than happy to give you my email. It's bcole@rushortho.com. There's one more question. With the growth and reliance on PAs and physician extenders, how do you ensure patient-athlete compliance? I think, this is all about delegation and responsible delegation. Surrounding yourself with people as good or better than you are is really important. And I think if you lead by example, your physician extenders understand the game, and they see it as one of their most important tasks to deal in the same space you would deal with if you had to manage every single aspect of an athlete's treatment, whether it be pre-surgical, non-surgical, or post-operative rehabilitation. So I think it's really hiring quality people is really what it's all about, and helping them understand how important it is to remain available, be responsive, and document everything, all these interactions. Those are some of the key issues. So I have great people around me. I trust them. We have excellent communication, and it is rare that I feel like we have any issues independent of the volume and the frequency of interaction with a particular patient. Another one is about burnout prevention. I alluded to those issues at the end of my talk, and I give a talk now on sort of balance in the workplace and in home and with research and clinical practice, and I'm far from perfect. I think some of the things that have been important to me are finding time, as I mentioned, for myself, and making sure that exercise is a big part of my week, and putting it in a place where no one can actually interfere with it. I think that's really important. I think the other thing is how you accept new tasks. In the business world, we talk about vertical integration versus horizontal integration. And I try to stay away from vertical integration, which means that if I don't have a skill set or a task that is not related to anything I'm currently doing, I try not to accept those new responsibilities. If it's something that is considered a horizontal integration, that you can leverage an infrastructure that you already have, that there's people that can help you with it, that your knowledge base is already there, doesn't have a huge learning curve, and you've already got sort of a foundation, those are much easier tasks to adapt to and take on as responsibilities. I think that's the comment where, if you want something done, give it to a busy person, but you've got to be busy in the right way. But accepting things that are not in your purview, that are completely outside the day-to-day structure of what you think, do, and have access to is probably can be a mistake as those tend to mount up. And then tasks just don't get done. The original sin is becoming an unreliable person. So trying to get things done responsibly on a timely fashion. And if you do delegate responsibly, and follow up with that delegation to make sure things are getting done, and the people that you've delegated to really know how important they are to you, and how much they're valued. Another question, how have you managed liability coverage with professional teams? will they cover you often or on your own? So in our situation in Chicago, we have additional malpractice riders for those of us who help take care of the athletes on a regular basis. We have standard malpractice insurance, for instance, coverage and total coverage, and then that's up to bit for professional coverage. There are some scenarios where a physician can be an employee of the team, and then allegedly the liability in terms of the ability to pierce the corporate veil and personal liability and so forth is improved. That situation can have reduced risk if you're actually an employee of the team. I think the analogy is a lot like workers' compensation, where, for example, malpractice is a tough situation, tougher bar when it's workers' compensation versus private patient. That's the model that some try to achieve for liability, but most teams won't subscribe to that, and that model, I believe, has been tested and has not always survived. So that's something you got to get good advice. Don't take this as advice, but you got to get good advice from your malpractice carrier. I will tell you the traditional model is that we cover our own additional expense on the premium side, and that the team itself does not really get involved in that area. I'd say that would probably be the norm, with some exceptions. Another question: do you see any future areas that need improvement with athletes' care, way to better train residents and fellows? Yeah, I think one of the things from the athlete's care point of view, when you look at the millions of dollars that are at stake when an athlete is taken out, either with traumatic injury or overuse type injury, one of the things that we've tried to focus on is what injuries actually have risk factors that are modifiable. And I think that's a big area, trying to identify certain injuries. I'll give you an example. For example, we know there's, say, 5 or 6 motor patterns that might predispose an individual to have an ACL tear. But most of those assessments are done at time equals 0 with a single activity to see, say, a box jump to see what happens to the hip, or if they go into net valgus, or they externally rotate the tibia, right? But very few of these tests are done after the athlete's fatigued. And when you look at when ACL tears happen, for example, in basketball, the vast majority are in the second half, and the vast majority of those are in the fourth quarter. So I think the areas that we can really make a contribution is in injury prevention and identifying those injuries that are related to potential fatigue, overuse, abnormal muscle patterns, strength and balance, and so forth. That would be that will continue to be a huge asset that we can bring to the table, collaborating with our athletic trainers and sports science people. I think what are there ways to better train residents and fellows in this area? Exercise physiology, sports science is a growing field. It's not something our residents and fellows routinely get. I think that for our program, we try to get the residents and fellows to shadow us. They may even cover high schools in the area, supervised by attending physicians. All of our fellows, for example, will come to the cover games. Will help with participation physicals, and giving them exposure early is really critical, so they understand the mentality of the system and how to interface with these individual athletes as well as the people around them, and more importantly, to understand things that are unique to a professional athlete or a college athlete that you may not see every day in your office. If you're on call, another question, 24/7, how do you incorporate that with trauma call for your institution? Well, in full transparency, when we did this talk, we were supposed to wear it on our sleeve. We take, I've been in practice nearly 20 years now, so I don't really have trauma call. It would be, the reality is the 24/7 concept is telephone the majority of the time. It's rare that there has to be an in-person consult for the most of the phone calls. But when they happen, they're not happening in the middle of the night in terms of face-to-face. It can happen in a away game and things like that. But the majority of that 24/7 is phone. And that's when you're seeing patients. That's sometimes when you're having surgery. When you're doing surgery, you get called. Obviously, you can't control when that happens. But being available and getting back to an individual quickly is paramount to maintain that communication. I don't have to take trauma call on any regular basis in my institution. Maybe it's 1 week a year, maybe 2. I'll tell you, though, that I'm not sure it would interfere, because that's a face-to-face concept where you got to go to the operating room versus 24/7 where you're largely outside of game coverage, and managing training room is telephone related. Another one, a related topic regarding PAs. How would you start to develop a new PA for a sports practice? One of my favorite topics is the PA the PA relationship. Just as an aside, a little shameless marketing, the AOSSM, we have a course in Steamboat I believe it starts February 7th in 2017. It's a 4-day course, and we're doing several sessions on the physician extender. And I think, and a lot of that will focus on the physician assistant. And the things we will do to develop a new PA is obviously shadowing, having a more experienced PA help teach them, and as I mentioned before, sort of leading by example. All super important, and it's a graduated level of independence, and making sure that you're meeting their goals. There's some PAs who don't want to be in the operating room. There's some PAs who only want to be in the operating room. Understanding at the outset is very important to maximize their job satisfaction, and the delegation and gradual levels of independence along a progression is really important, but always sitting down on some regular basis to evaluate them. The PAs I've worked with are generally no less than amazing. I mean, they have some of the best sort of practice mannerisms. I have patients who come in and they ask for where my PA is. They don't. The first thing they'll say is not how are you. They'll want to know where the PA is. So I think it's fascinating if you can help that PA develop, let the patient know that they're an extension of your practice, and manage expectations of the patient. You can really grow in a nice relationship. It can help you maintain balance and understand that PAs are not always generating revenues, but they're generating quality of life and balance. So I don't value my PA by how much money they make. I value them by the intangibles in terms of what it frees me up to be able to do, both with family, with other aspects of practice, with research, travel for academic commitments, and so forth. PA can make your life far more balanced and rewarding. Timing of MRIs for injured athlete in season. The timing is yesterday. It's insane how quickly we order MRIs for our athletes. How they're frankly mostly do not translate into anything of high value, but it's the system we function in, and in some respects it's expected by the athlete, sometimes by the system. That being said, I'll give you an example why MRI is really important. For example, we now, for the most part, will pre-season MRI our athletes' knees, because when we found, and this was published in 2008, that we had about a 35 to 40% incidence of MRI findings, such as osteoarthritis or meniscal tears. And if an athlete gets injured and has knee pain or a little bit of an effusion, and they knew that was there before, you can quell a lot of fear and concern that they're going to make something worse. That say this isn't a new injury. You get a sense of what you can inject safely if you want to go that route. So it really helps you educate the patient. Now, obviously it's expensive, but in these systems, the threshold for getting an MRI is incredibly low. And those of you who take care of high-level teams, I would advocate that you consider it. Our baseball, they all have shoulder and elbow MRIs, and it can be very helpful in the setting where there's an injury to figure out what's old and what's new in terms of educating those in the system. So it's been a huge asset to us. We've even gone to the point where we're even considering doing lumbar spine, because one spine injury, for example, where a guy has low back pain, but maybe a little bit of referral down towards the gluteal region, and then you get an MRI that shows what everyone has, maybe a bulging disc. Trying to explain that away when it existed before can be really difficult when you don't have a baseline MRI. So huge cost. Economically doesn't make sense in the mainstream, but it may make huge economic sense to reduce time off to allay concerns and get an athlete back faster. What is the most common cause of inferior shoulder instability? Glenoid bone loss, Hill-Sachs, capsule, or ligament issues? Well, I mean, anterior inferior instability is really the direction that we deal with most. And I will tell you that if someone's dropping out inferiorly, it's a little, peripheral to our conversation tonight, but if someone's dropping out inferiorly, many times glenoid bone loss comes around the corner and will reduce the ability for the shoulder to translate inferiorly, and it becomes a true bidirectional problem. I would say capsule and ligament is also an issue as well, and those are people who come in as bidirectional instability, non-traumatic, who have a bidirectional component with inferior instability as well as anterior or posterior. How do you handle a professional athlete that you know post-operatively will likely be non-compliant? Yeah, so I think that, again, we can't control what everyone does. This is an area where you want to document every step of the way. It's not that you're trying to assign blame, but I think that it maintains transparency. Helping the athlete understand the consequences of his or her actions and how it might compromise their outcome is really critical. Helping them understand that it's just not a whimsical recommendation, but it's based on something that's very scientific, that's in your own experience, and there's a reason for it. And if you don't have a good reason for it, maybe there's a compromise. And certainly ask them, say, look, what issues do you have with wearing the sling? What issues do you have with wearing with protected weight bearing? And try to help them understand the consequences of action. I mean, you can only do so much for some people. This is not unique to a professional setting. That being said, I think if people are educated properly in most settings, hopefully you can prove the compliancy. But just I think really, really critical is to make sure that you educate and document very carefully. You just don't want things to come back to bite you. And frankly, I think that it just helps the whole system if every step of the way is documented during the course of an individual's care. So I think, Kelsey, I think we're 7:58. I enjoy doing this. I appreciate you all taking your time out on a weeknight to indulge in this conference, in this presentation. And I wish all of you a nice evening and weekend.